Good evening, everyone. Good evening, good evening. Go. Good evening, everyone, and welcome. It is Wednesday evening, and we've got another Fertility Talk. And tonight we've got Dr. Dries Potgieter. So there's quite a few of you coming on already. And we're going to talk about PGT-A this evening. It's something that I've actually never spoken about, so I'm quite clueless on the topic. So this evening's topic is going to be quite a good discussion. I'm just going to invite Dr. Dries Potgieter is a obstetrician and a specialist obstetrician and gynae from Genesis Reproductive Centre. So we're just going to try and invite him now to evening's conversation. Let me go. We've invited him. So we'll just wait a couple of minutes. Thank you, everyone who's joined. That was quite quick. Hi, Doctor.
Hello. How are you?
Good, and yourself?
No, good to hear your voice. I'm glad we're on.
Yes, that was very quick. I'm very glad it went well this evening. So if any of you joined us last night, you would see we're doing a whole lot of testing. I hope I didn't irritate anybody with the testing, but I'm glad we did that. So it made this evening so much easier. Thank you for joining us. And like I said, this evening's topic is something that is really quite out of my league, completely out of my league, because I've never actually discussed this. Never gone through it. So it's quite new to me, and it's going to be quite interesting to hear exactly what it is, why it's important. And you're the one with all the answers for us. So please, first of all, introduce yourself to our audience. Tell us who you are, where you're from, why you do what you do.
Oh, thank you, Leanne. Thank you for the opportunity. Firstly, I want to say thank you for the opportunity for giving us a platform to connect with our audience, and hopefully we can talk about something interesting tonight and learn. So I think the idea is here that we are here for one goal, and that is for the women to help them to have their families. And we understand that that is a need, and that's why we're here. We're all to help. So you must never feel helpless. There's always help available. So I am at Genesis Reproductive Clinic in Mediclinic Kloof here in Pretoria. And we are 3 specialists that work there. And we've got a wonderful clinic. And one of the services we do offer is PGT-A or PGT testing, previously known as PGS or pre-genetic testing. And we would like to just talk a little bit about that. So just a little bit of my background. Yeah, I've got a long background. I think, I always say that I did medicine a long way around. I first did a nursing degree, and I think if you're 18 years old, you never really know what you want to do. So anyway, so I did that and finished that. And then at 24, 25, I decided, no, I'm going to go back to medical school. And then, from there on, I think the rest is just history. And here we are today. So we're very fortunate, and I'm sure we're going to have a lovely talk.
Okay, great, Doctor. Thank you for that. So we're going to get right into it, because we've also got a few questions at the end of it. So if you guys or whoever's out there listening, if you have any questions, please put it in the comment section. We can ask Dr. Potgieter at the end of it. If there's something that he cannot answer, we will just give you his details. He will drop his details, and you can then email it straight to him, and he'll be very happy to assist you with that. But the first question is, what is PGT-A?
So basically,
I think we have to start with the basics here.
Yeah. So PGT-A is testing that we can do on individual embryos in the laboratory, and we can actually we can check for genetic abnormalities. And normally you can do that for up to 5 days, 4 or 5 days before you implant that embryo back into the uterus where it belongs to form the fetus. So usually this is done where you take a biopsy from the embryo after fertilization. So it's normally after IVF or ICSI. So we know IVF and ICSI is not the same thing. We know that IVF is where we have sperm that fertilize the oocyte to form an embryo. And we know with ICSI, which stands for intracytoplasmic sperm injection, is where when we have a poor male factor, and then what we do is we actually inject one sperm into the oocyte, and that helps to form the embryo. But there's two types of testing. The one testing is the so-called PGT-A, so that's where we look for, is a screen for aneuploidy, and also it goes with it is PGT-M, which check for single gene disorders or mutations, and then we also have PGT-SR, which looks more for unbalanced chromosome rearrangements. Now we know if we look at a normal, a normal-looking embryo contains 46 chromosomes, and there's 23 pairs. And we know that from the 23 pairs, there's material of the male and the female, or the husband and wife. And we also know that the 23rd pair contains the sex chromosomes, which is the X and Y. So that's very interesting, because patients always ask me this, and I always say, remember, the daddy decides if it's a boy or a girl, and the mother decides how many babies. So that's quite interesting, the way things work. And then, as we said, that PGT-A will look for that aneuploidy, and our examples of that would be things where you're an extra chromosome on chromosome 21, like Down syndrome, or Pgta syndrome on chromosome 13, or Edwards on chromosome 18, or Turner syndrome, where there's one chromosome missing, or Klinefelter, where there's an extra X chromosome. So those are basic, kind of like genetic abnormalities that one can, obviously, with PGT-A look for. And there might be a lot of other abnormal chromosomes from 1 to 22, but most of them are actually causes miscarriages, or they cause failed implantation. Now, if you look at, so PGT-A will definitely help you to identify the likelihood of a normal embryo that would lead to a healthy pregnancy, but aneuploidy is definitely also linked to age. So one must understand that, unfortunately, age is a woman's biggest enemy. And it's not just because you get wrinkles and you get older and you have to put on your night creams. It's also because your age, unfortunately, your oocytes or your eggs is just as old as you are. So by the age of 35, you've got about 50% aneuploidy. So by 35, about half of your eggs are not 100% normal anymore. And by the age of 40, more than 80% of them are aneuploid. So it really shows you. So that's why if you go to the doctor and you are much older, the doctor, the specialist will always tell you that you should maybe consider donor eggs if you're at advanced age, because with donor eggs, we know that studies have showed that you've got a much better risk of having a healthy live pregnancy compared to when you try and use your own eggs. So that's basically just, in short, a nutshell to what it is.
Yeah. So I'm even just by you answering that first question, I'm already seeing what the reasons for doing this test is, how important it is, and especially if you're doing IVF and ICSI, I would actually can save you quite a bit of emotional trauma and all those things that goes with it, and especially financial as well, because you're doing the test and making sure that the egg that has been transferred is a good one. Am I correct? By just picking up what you're saying?
Yeah. So that's absolutely correct, Leanne. So the idea is that you try and try and find the best possible embryo to implant that's going to give you, that healthy baby or that live birth. But if you look at the main indications, like we said, the one is definitely your advanced maternal age. So if you the second one is if you've got repeated miscarriages, your doctor might say to you, I think we should look at doing PGT-A. If you've got a repeated implantation failure, and that is a complete subject on its own, which we can tackle at some other stage. If you've got a severe male factor, or if you've got genetic abnormality in your family, like if you've got a known familial translocation or inversion or gene duplication or deletion, then obviously it's definitely worth it to go and look for it. But with that as well, you won't just do PGT as well, but you also would do then chromosome analysis and all of that. So so basically, that is the main indications for PGT-A.
Okay. The next question is, how is PGT-A performed?
So basically, so we've got lovely people working with us in the laboratory. They are called embryologists. Now, embryologists are people that they they normally hide behind the windows in the laboratory, but they're actually very nice people. And what they do is then they take a biopsy of these embryos for you, usually about 3 to 5 cells, and it's taken from the trifectoderm of the embryo. So let me explain to you. So an embryo has got two parts. It's got an inner cell mass, and it's got a trifectoderm. Now, the inner cell mass is the part that normally forms the fetus or the baby, if I can put it like that. And then the trifectoderm is the part that will form the placenta that will look after the baby until the baby is born. So if you take cells from a trifectoderm, then obviously there's less trauma to that specific embryo. So then what happens is there's specific companies that actually look at these cells and analyze them for us, and then obviously we can decide and say, okay, we're going to see what do we need to do for you in terms of your further management.
Okay. Is PGT-A of my embryo safe?
Well, you see, I think that's a very interesting question, and I think there's a lot of data if you go and look, and we're happy to obviously send that to people if they want, but there's quite a lot of data that say that there is no real negative effects on newborn babies or previous newborn babies that had PGT-A. So that is, generally it's a safe procedure you do, and that obviously providing that you do it in a cared for manner for the embryo in the way that we described it.
Okay. Was there something else you wanted to say? Sorry,
yeah, no,
I cut you off.
So I think the next thing that we have to look at is obviously the result. So if you send it away now and your report comes back, you can expect different things. Now you can expect that it can say it's euploidy, means that your embryo is normal, or you could have a thing that says it's aneuploidy and it will give you the abnormal amount of chromosomes, so that we know that's not a normal embryo. And then we get a concept that we call mosaicism. Now that's a difficult concept, and we'll talk a little bit about mosaicism, because that's where you have 2 or more cell lines in that specific embryo, and then we need to decide, what are you going to do with an embryo that is mosaic. Yeah.
Okay, so the next question is, did you do the one of, you actually explained now how do you interpret the results?
Yeah.
Is that correct?
Yeah. So
okay, now what does the results of the PGT-A mean?
So basically now, so you've got you have got your results. So if you, unfortunately, PGT-A is not the willing and all. If you've done a PGT-A and you've got a normal, it says you've got a normal embryo, there's still no 100% guarantee that each and every genetic abnormality is excluded. Unfortunately, there is no test to say that embryo is 100%. But what you can say is that it's so important that we know that the patient must be counseled before and after the tests, so the patient can understand exactly what is going on. And now some studies has also shown that there's a big discrepancy between the difference of cells between the inner cell mass, like we spoke about, and also the trifectoderm. So it could mean that the trifectoderm doesn't represent the whole embryo, and the inner cell mass might have different cells, and this is where the concept of mosaicism comes from, and we'll talk about that. So there you have to do absolutely in-depth counseling if you do find mosaicism, because you have to decide now, are you going to transfer a mosaic embryo back? And if you would transfer a mosaic embryo, what can you expect? Because there is such a thing that we call a self-correction. So self-correction can also occur. So it is a difficult concept, and that's why I think it's very important that you need the geneticist as well that can help you from that point of view.
Okay. What is the benefit of the PGT-A overall?
So having said now that since I've pictured a bit of a gloom thing now, is that PGT-A, if you do, there is such a thing that we call ESET, so elective single embryo transfer, and we are all heading towards the selective embryo, single embryo transfer now, because we know that multiple pregnancies it's just, you know, if you have more than 2 babies in the uterus, it's more dangerous for the women. It's also more dangerous for the unborn babies because there's a very high risk of premature labor, for high blood pressure in pregnancy, rupturing of membranes, all these diseases that can go with that while you're pregnant. And now we're all moving towards the single embryo transfer. So if you do PGT-A and you've kind of like said that you think this embryo is normal, then it will help you when you specifically do single embryo transfer. And now the studies has definitely showed in women that are older than 35 years, there's definitely less risk of recurrent pregnancy loss, especially in women older than 35 years. And the studies have also shown that there's a shorter time to pregnancy. So if you look at, in other words, the studies have shown that it actually, if you do PGT-A, it can lessen the time to get pregnant and have a normal pregnancy by at least 3-4 months. So it does help you with the process as well. And then obviously, if you've tested an embryo, then there's obviously a less risk of it failing, you know, when you do transfer it. But having said that, PGT-A is definitely most beneficial in women that are older than 35 because of the fact of aneuploidy and the abnormal embryos that you get with older age. But it's not really been, if you can look at the American Society of Reproductive Medicine, 2018, it will tell you that it's not yet been established as a, let's say, almost as a screening tool. So you have to basically use it according to your patient and you have to individualize it. So I think you have to speak to the patient and look at the history and then decide if you want to, you know, use it or not use it. The problem is just more looking at more on the negative side is that the studies have shown, we know that if you look at certain trials, it's called the STAR trial, and there's also was a trial that followed after that, which is called the shooting star trial, and those trials have showed that if you do PGT-A on all the embryos, there's a very high number of mosaicism, and that's associated with a lot of embryo wastage. In other words, you can get a lot of embryos that look abnormal that are actually normal. So you must definitely have your indications correct when you do PGT-A. I don't know if that sounds clear to you, Leanne, but I think your specialist will definitely help you, you know, in that manner.
Okay. Well, the last question that I have for you regarding PGT-A is into the future with PGT-A. What can you tell us about that?
So I just want to talk a little bit about to the audience about the future. So now there is such a thing called the non-invasive PGT-A or non-invasive embryo testing, which is less traumatic because you don't physically have to take cells from the embryo. So if you put the embryo in let's say in a culture medium, you can actually subtract the cell-free DNA from that culture medium, which can actually give you that input from the inner cell mass and the trifectoderm. And I think that will help us a lot in the future, in terms of, you know, where we're going to go in terms of non-invasive PGT-A. And I think that's something that we have to watch the space for, because it's something I think that is definitely going to, you know, something that will kick in, that we'll see in the future. So as soon as we have more availability of that, you know, obviously then one can look at that as well and see. Now, if you look at these things at subspecialty level, sometimes there isn't always a right or a wrong answer. You know, each and every patient have their own specific cycle, the way they do things, and it's so important for the specialist to be to be able to adapt to each and every patient and the cycle and what their needs are and what they want. Because some patients prefer not to have twins, and some people prefer to have singletons, and some people don't have any children. So for them, you know, all these things are very, very important. So each and every patient is unique, and that's why then we bring all the testing forward and we say, okay, where does it fit in, and are we going to use it for you or not? So I hope that helped a little bit, just in trying to explain, you know, of what, you know, what does it mean and how does it fit in.
Okay, absolutely. Thank you. I've got a question here. How much is PGT-A? Sorry, how much is the PGT cost, or the estimate? And do you guys do it at Genesis?
Yeah, we do it at Genesis. So the thing is, and if you look at PGT-A, unfortunately, PGT-A is one of those things that it really becomes much more cost effective if you do um, more than one, two, or three. And I'll explain to you the following analogy. When you go and buy fishing gear, and you want to go and catch some salmon in the sea, so it will cost you 1,000 rand to get all the fishing gear that you need. And that first salmon that you catch actually costs you 1,000 rand, because that's what you need to get the bait and the fishing rod and everything that you needed. But the more fish you catch, the less expensive it becomes. You understand what I'm saying? So it does.
Absolutely.
It's quite expensive. So you're looking at each and every laboratory does have specific prices to it, and we're obviously happy to help with that depending on your situation. But obviously, initially, if you're going to do more, there's obviously cost involved. But obviously, if you do more to a certain number, it's definitely then more cost effective, if you know what I'm saying. But if you're just going to then I think everybody do have their standard price. It really just depends on what lab you use, because we use additional labs to obviously where it goes to. Sometimes it goes overseas to America or wherever, the other laboratories is. We don't do the physical genetic testing in the laboratory. It has to be sent away to the other laboratories, which we can give the details of. Then we can give that details if needed. Yeah.
Okay, we've got another question here. So above the age of 38, are you saying it's a must for a couple to add PGT-A to their treatment plan? Or you're just saying that it's advisable? It's
advisable. If you look at, I know that, it depends also on the laboratory, but I think you have to look at, yes, do you have previous miscarriages? Have you had previously failed implantations? What is your history? Have you ever had any problems? Because the embryologist is really helping you a lot, because I can tell you what is the quality of that embryo looking like. So when you've got a very dark, pigmented, not good looking embryo under the microscope, then your embryologist will say to you, you know what, we should rather look at maybe doing PGT-A for this patient, because if you just are looking by there's a different grading system. There's a Gardner grading system. There's lots of different grading systems for embryos that we use. And that side, I suppose if it's your treatment plan that you want to do it through the bank for everybody, I suppose then that's your decision how you want to do it. But I think each and every patient should be evangelized.
Yeah. Absolutely. Thank you. Do you mind answering another 3 or 4 more questions?
No, we can go for it. Go for it.
Okay. So I've got it from a lady. If there's anything, doctor, that you're not wanting to answer right now, please again give us your details, and we can get them to contact you directly. So one of the questions is 2 ectopic pregnancies last year. Left tube HSG says open but lots of fluid. What is the chances of a natural pregnancy?
So obviously the one thing is that one need to look at to see what is the reasons why you've got that. Why is that you've got fluid in the tubes? I mean, could it be that mean that you have a salpingitis? So there could be infection or inflammation in that tubes. So you need to go and see. So a tube that's swollen up and that's full of fluid is not normal. So that has to be investigated. In terms of that. And like I say, each and every patient is individual.
Okay, perfect. And then they just want to get your opinion on frozen or fresh, which is best.
So if you go and look at the data at the moment, there's a big push now towards frozen, and there is also benefits to that. But like I say, you also have to individualize, because the frozen cycle or the frozen all cycle it's got its own place, in the sense that if you've got a patient that's got a risk of what the so-called ovarian hyperstimulation syndrome, or then it's always better to do a freeze-off cycle and let the patient first cool down and then going back to your embryos, because once you end up with an ovarian hyperstimulation syndrome, it can be very dangerous to that woman, because we get an element that we call VEGF, vasoendothelial growth factor, that causes this the fluid shift in the compartment. So you get a lot of fluid accumulating in the abdomen, and it can be quite dangerous, and you get different levels. So that's something that's one of the main complications of IVF stimulation that we want to stay away from. And then, like I say, if you can do fresh, definitely, I think you should go for it. But I think if you look at frozen embryo transfer, there's very good results that we are actually getting frozen and fresh to be very, very similar. Especially if you go and look at the data from the University of Valencia in Spain, the so-called EV group. They've done a lot of research on it, and yeah, it sounds to be very interesting to see what's going to happen. Yeah.
Yeah. Okay, we've got one more question that came up there. Is there any risk of birth defects? Obviously,
Yeah.
with doing the
Birth
PGT-A
defects.
test.
Yeah, so the thing is, it depends on what you mean by birth defects. I think Lizelle was asking that. And the reason for that is because it depends. Are you talking about birth defects in terms of the abnormal embryo, or are you talking about birth defects because you punctured the embryo? Now, Lizelle, what I can do is she's welcome to drop me an email, and I will send her all the studies regarding that. Otherwise, she's welcome to come and see me in my rooms, and I'll discuss it. And yeah, Lizelle, we've met before. I know quite well. Yes.
Okay, great. Great. The last question from someone was low morphology or low sperm. You know, if you had to choose between the two, what is your chances of conceiving with
Okay. So
either?
yeah. So the most, we always thought it depends. It really depends on what type of fertilization you would do, because if you've got a low morphology, even of 1%, and you've got a relatively normal female with open tubes, and you've got don't have any DNA fragmentation on the sperm, and you've still got relatively your sperm count is still relatively good, then you can still do IUI. So it doesn't mean if the percentage is 1% and the morphology is low, you have to go straight for IVF. So there is certain cases where you can still do IUI and still have success. But there's obviously other female factors that you also need to look at. But you have to have the whole spermiogram in front of you. Remember that a spermiogram has got quite a few elements that you need to look at.
Yeah.
So not just morphology and count, there's other things that are also important.
Okay, great. Well, thank you, Doctor. If there's anyone else that would like to get hold of Dr. Potgieter, if you have any questions, please give us, you can contact him at Genesis. Do you want to drop your email address for the viewers?
Yeah, so I just, what we can do is I can just type it here in the comments. So I'll do that for you.
Okay, so Doctor will type it in the comment section there. So if you'd like to get a hold of him, please contact him. He is at Genesis Reproductive Centre, and that is in Kloof in Pretoria, am I right?
Oh yeah, yes.
And they're a great team, and we'll have the rest of them on throughout the year. So guys, thank you. On Friday, we're having a talk over on Facebook. That would be regarding male infertility. So if you have any questions regarding that, please, at 12 o'clock on Friday over on our Facebook page. There are about 28,000, I checked of you, 28,000 followers on the Facebook page on Friday. So please join us there. It's with one of the embryologists at ReproLab. So thank you very much, Dr. Potgieter, for taking your time to chat to all the ladies. I know we're going to see you again, and do some more talks with you. But thank you very much for doing this for us. Have a great evening.
Thank you very much for your time. And we are three specialists at Genesis. It's myself and Dr. Aubrey de Bruin, and it's also Dr. Good luck, and thank you for the opportunity. Goodbye.